Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and in today's episode, we're lucky to have a special guest to discuss traumatic cardiac arrest or traumatic arrest. This is an area of EMS care that's undergone significant dogma challenges over the past couple years, so it always makes for a good topic to discuss when what we have always done now becomes maybe questioned a little bit. It seems pretty obvious to me that advanced cardiac life support, or ACLS, is a medical approach. Unfortunately, those approaches made their way into pre-hospital trauma care, and those habits have died, or they're dying pretty hard in the management of traumatic arrest. So let's get to some clinical goodness. First of all, we have a special guest today, Lindsey Ewing. Lindsey, can you please introduce yourself and tell the listeners how this topic came to your attention? Because we sort of met with the idea that this is a topic we need to discuss.
Yeah, absolutely. So my name is Lindsey Ewing. I'm a critical care flight paramedic out on the East Coast. I've been doing that for the last 5 years. And prior to that, all of my EMS experience has been 911 stuff since 2006. I do lots of education for paramedics and pre-hospital providers on the side in real life. And then I also run the Prehospitalist Instagram page for some virtual learning, which is kind of how you and I got connected today.
Well, it's awesome to have a guest out there discussing this stuff with us who are trying really to do the same thing that we are here at the podcast, maybe in a different way. I'm not an Instagram guy, but definitely have seen your content and it's awesome. And so for you to be a pre-hospital provider out there providing care for these traumatic arrests and trying to educate makes this a pretty good combo. So let me start with a few disclaimers for the MCHD listeners and for the regular listeners. There's a ton of decisions within traumatic arrest to unpack. So a couple quick reminders for the audience. We don't have blood products for now at MCHD. So if you start to scream, what about blood? What about blood? What about blood? Well, we don't have it yet at MCHD. There's lots of topics and conversations and discussions that are being considered and that are undergoing. So just hold that thought. We'll discuss some general topics and some generalizations. And when there's an MCHD protocol alert, if needed, I'll chime in there. For an MCHD protocol reminder right off the bat, who always gets transported: pregnant patients, patients with electrical activity at a rate greater than 30, shockable rhythms, or at the medic's discretion. If you have, for example, positive squeeze on carotid point of care ultrasound, if you have an increasing end-tidal CO2 delta, we'll get into some of these a little bit more, those get transported. The flip side, asystole in trauma is considered incompatible with life. Yes, I understand the East and the West trauma guidelines, and that's a bit different than what they say, and those are hospital-based. We're talking about our decision made on scene in Montgomery County. So disclaimers made. If you have questions about those, always email us. But getting to Lindsey's experience and some of the concepts that we have sort of discussed and realized can be confusing, let's start with the concept of reversible causes in trauma. What are they? Because this will lead us, more importantly, into what they are not. And this is really, to me, the root of the confusion that occurs in managing these cases.
Absolutely. And so I'm going to start with a quick story because I have always been really intrigued by pre-hospital trauma resuscitation. There's very limited things that we can do, so we should be doing them well. But I had a case some time ago that really brought some of the issues we're going to talk about today to the forefront. And that patient was a young adult who had multiple sources of penetrating trauma to the chest and torso. When we arrived to the patient, they were receiving positive pressure ventilation in between intubation attempts, but SATs were 100%. Very quickly, those patients' SATs dropped into the 70s. So we said, let's just drop an eye gel and see what's going on here. iGel had great end tidal return, but SATs were still trash. So we listened to lung sounds, find absent lung sounds on one side. So we do a quick finger thoracostomy with obvious air and blood return, and SATs very quickly return to 100%. Makes sense, right? Penetrating trauma plus positive pressure ventilation equals tension pneumo. So we ended up having this patient for over an hour total time during transport, and they were profoundly hypotensive the entire time, received multiple units of blood products. They received TXA, calcium. Patient was delivered to the trauma center with a narrow complex tachycardia, with an end tidal that had been consistent throughout transport and was consistent with life, okay, and SATs of 100%. Very soon after we turned the patient over with those same vital signs, someone in the room said, I don't feel a pulse. And that was not confirmed with POCUS, and very quickly chest compressions were initiated. And we could see from afar that the patient had some subtle but fairly clear purposeful movements during compressions. And during that resuscitation, the patient pretty quickly deteriorated into an asystolic arrest and never recovered. So this case brought to the forefront a couple issues that are amidst what we're going to talk about today. Number one, what is the role of chest compressions in trauma arrest? And is there a potential to cause harm with them if we are not doing them at the appropriate time? And then number two, how are we defining trauma arrest? Because just because a patient doesn't have palpable pulses, especially in the presence of trauma, that does not necessarily mean that they're dead, right? So if these patients have a viable EKG and a viable end tidal, they're most likely just profoundly shocked, and we should be treating them as such, right? So those are a couple of the big issues that we're going to talk about. But Dr. Patrick, like you asked, like what are the reversible causes that we're talking about here? We addressed a couple of them in this case, right? But this is a short list, which makes it so easy for us, right? Like there's only a few things that we can actually do anything about. So we need to make sure that we're checking our boxes. Number one is a hypoxic arrest in trauma. This could simply be the patient that had a non-lethal TBI but was rendered unconscious and then ended up having an airway occlusion from their tongue, blood, other secretions, whatever. And then they go into arrest because they weren't oxygenating and ventilating adequately. These types of patients are low hanging fruit. All we have to do is ventilate them and oxygenate them. That could be with a bag valve mask, that could be with your iGel, maybe an ET tube if necessary, right? But that is kind of the beauty of end tidal, is that you can put it in line with your bag valve mask and ensure that you're getting good ventilation. So that's probably the first step in all of these patients, just to check our box and make sure that this wasn't an obvious just hypoxic arrest from an airway issue. Do you have anything to add on that before I move on to hemorrhage?
Well, I'll just move you on into hemorrhage and say I believe correcting hypoxia, making sure that we're oxygenating and ventilating, is the first step, unless you see external bleeding.
Sure.
And so I believe that the only time that you would not start with oxygenation and ventilation and kind of that ABC, CAB approach, the difference there in medical and trauma is that if we've got blood on the street, then we've got to figure out where the tourniquet's going to go and put one, put two, high, nice and tight, making sure that we're slowing down that external bleeding. So that rolls us right into number two, and that's hemorrhage.
Absolutely. I mean, we don't care about air going in and out if there's no blood to carry it round and round, right? So obviously control any external hemorrhage. And then beyond that, one of the most common causes of potentially reversible traumatic arrest is hypovolemia from blood loss. So you already mentioned, there's no blood products at MCHD currently. However, it's very important for clinicians to be able to identify patients that need that, right? If they have the peri-arrest patient who is obviously in hemorrhagic shock, that's only going to be reversed with blood products. So getting them rapidly either to HEMS or the trauma facility, whatever is appropriate in your area where those blood products are available, should be high on the list. These patients can certainly tolerate some bit of a crystalloid bolus, but by now, I think we all know that crystalloids fix nothing in hemorrhagic shock. They're typically cold unless they're on a warmer. They're acidotic. They worsen coagulopathy. So dumping liters of normal saline or LR into a patient isn't helpful, but getting them to somewhere where there are blood products is certainly high up on the list.
I throw TXA in there. It's
Yep.
not going to be a Lazarus drug. We're not going to raise people from the dead, but if you have time in that decision-making process of, yes, we've got to get to definitive care for source control plus or minus blood products. If you don't have those available, if you can get TXA on board, it's always, always, always a good idea. It's really the same number needed to treat in the range of aspirin for STEMIs. So think about how serious we take aspirin for STEMIs. That's how serious we should treat TXA for trauma patients who are peri-arrest, bleeding, and believed to be in shock from blood loss. Your case had another curveball. It wasn't just a bleeding situation. You had some tension. So talk about tension physiology and how you treated it in your case, and some of the options that we have in the field.
Yeah. So when we're dealing with trauma arrest or your severely, peri-arrest trauma patients, if there is presence of chest trauma, either known or assumed because it's, multi-system ejection or something like that, empiric bilateral chest decompression is absolutely indicated. So this could be done via needle decompression or finger thoracostomy, depending on what is available to you. I will argue until my last breath that finger thoracostomies are probably safer and definitely more effective than needle thoracostomy, but whatever is available to you, certainly appropriate. We are not doing this for the single gunshot wound to the head arrest, right? Like these are for patients that have some indication of chest trauma. Now, there's often a clinician that says, but lung sounds, shouldn't we be checking lung sounds first? And I will certainly see what you have to say about this, Dr. Patrick. But when the indication is there in a trauma arrest, there is no place for lung sounds here. Lung sounds are extremely unreliable, even in non-arrest situations. I mentioned this to you beforehand, but I did a deep dive recently into a whole bunch of cases from all over the world of unidentified esophageal intubations that led to patient death. And a huge majority of those cases had present equal bilateral lung sounds documented by anesthesiologists. Okay. So if we can't get this right in the hospital, in like living patients, when there were no lung sounds, how are we going to get this right out on the street with a trauma arrest? So if the indication is there, just decompress bilaterally, go ahead and check that box in case the tension was there.
There's probably an entire episode to discuss here. I will say that National Association of EMS Physicians just released a position statement on this topic, and yes, finger thoracostomy is superior to needle decompression for actually relieving tension physiology. I believe that is a safe statement for us to make. Who these are performed on in the field with what protocol check boxes that need to be met before you do it is going to be service specific and resource specific. We perform finger thoracostomies here at MCHD in traumatic arrest patients. It does take a significant training and education load, and we've worked hard on it for over a decade now to be proficient. But I believe your example is very key. The single gunshot wound to the head, that does not warrant finger thoracostomy. There is a risk of medic injury with a scalpel, with fractures in ribs and other things that can be there. So it's not an entirely risk-free procedure. The indications for performing this potentially in the peri-arrest patient, the patient who is not dead yet, those are definitely evolving. Breath sounds are absolutely fallible. Are we going to incorporate lung sliding and point of care ultrasound into these protocols? There are a lot of places to discuss details here, but I would say that in the case of a traumatic arrest patient, which is really who we're talking about here, who has multi-system trauma, penetrating chest trauma, that finger thoracostomies at MCHD are indicated, and we believe that's best evidence at this point. Needles, if you're out there using needles, or maybe your protocol does not call for finger thoracostomy in a peri-arrest patient, make sure we're putting needles in the right place, make sure we're using that anterior axillary line or mid-axillary line, fourth or fifth intercostal space. and that you're understanding that they're likely not to work, so you're skeptical about the needle success even before you get started. And that brings us to the last space that pressure can build. This one is definitely one that we've evolved away from at MCHD, but is worth discussing. And that's not tension in the chest, thorax cavity. That's tension around the heart. So let's talk about that one.
Yeah, the very last one on the list here is our cardiac tamponade. And this is definitely the trickiest in the pre-hospital environment. We have to acknowledge that it is a potentially reversible cause of arrest, but for us to fix it pre-hospitally is going to be very challenging, and it's going to depend on guidelines and likely ultrasound availability. So if the patient, especially if they have penetrating trauma to the chest, that's when we should be suspecting tamponade. So some guidelines will allow for blind pericardiocentesis in true trauma arrest. However, there's obvious skepticism towards that because sticking a very large needle into a very important cavity without actually looking at anything is kind of sketchy, right? You can discuss that. I'm not sure what your guidelines are as far as POCUS and pericardiocentesis, but it's something that we should at least have in our mind as a potential reversible cause.
It's going to depend on training. It's going to depend on your ability to ensure that you can do this procedure properly. I believe that in the emergency department, blind pericardiocentesis is extinct, that we all should be using ultrasound for this procedure if we're doing it. We don't currently perform pericardiocentesis at MCHD, and really it's a trauma data reasoning and nothing more. Our penetrating to blunt trauma ratio is 85-15. Blunt to penetrating is 85-15. In other words, 85% of our trauma is blunt. Half of that penetrating is self-inflicted GSWs to the head. So less than 10% of our trauma is true chest, abdomen, within the box penetrating trauma. So it's just not something that we feel like is a priority when we look at the patients that we actually see to warrant such an in-depth and continuous, time-consuming, expensive training and oversight and management of a procedure like that. Not that if you're in a different situation where you have a much higher penetrating trauma ratio, then maybe you're performing pericardiocentesis. It just has to be done like any other procedure with a nice tight protocol, with good oversight, with good training, and continuing education. So in those reversible causes, and that's really all of them. Now we can think about straightening long bones from a hemorrhage standpoint. That's one we didn't mention, but really we hit most of them. And there's a piece in there that we didn't mention at all that often is educated within traumatic arrest resuscitation, and it really goes back to your case and your question about compressions, Lindsey, and what are some of those things that we didn't mention that often get mentioned when we talk about arrests in the field?
Yeah, so what we're not talking about here is basically all of the etiologies that benefit from rapid, high quality chest compressions and potentially early epinephrine, right? So things like your acute MI, your congestive heart failure, your pump failure from atraumatic causes. These are all patients that benefit from really good, high quality, immediate chest compressions. So, Dr. Patrick, can you talk us through a little bit of the literature that exists about chest compressions in trauma arrest? Are we convinced that we shouldn't be doing it, or is the jury still out?
In a vacuum, I believe that if we are sure that the patient has traumatic arrest, that there is very little role for chest compressions and there's little role for epinephrine. And that hedge there at the end, there's little role, is my answer, really. And I think that the pendulum is swinging. I don't know that there is a massive load of evidence that exists, but we're definitely moving in that direction. And you can look at position statements from both Australasia, from the United States, from American College of Surgeons Committee on Trauma, National Association of EMS Physicians, ACEP, the American College of Emergency Physicians. A lot of the wording behind, do we do compressions or not, do we provide epinephrine or not, is becoming very, very minimal, with some folks going as far to say no. So let's talk about a little bit about why we've not said no at MCHD yet and sort of some of the details here. There are a lot of theoretical reasons why chest compressions could potentially worsen outcomes in trauma patients. They've already got trauma, and we know that chest compressions, whether mechanical or with uh, manual compressions, cause chest wall trauma. We've all felt that rib fracture. So you've got somebody who's got multi-system trauma and you add some rib fractures, well, theoretically, that's going to make them worse. There is some animal data as well suggesting worsened outcomes in traumatic arrest with external compressions. Again, that's animal data, but it's there. There's also a recent retrospective look at epinephrine in traumatic arrest in pre-hospital emergency care. That's Witt et al. We'll include that one in the show notes. Blunt trauma did worse when receiving epinephrine. There was no difference when the penetrating trauma patients received epinephrine. This was retrospective. There was bias that exists here. This wasn't a randomized, blinded, controlled, prospective study. But it makes sense that giving epinephrine to someone who has hemorrhagic shock or pericardial tamponade or tension pneumothorax or a combination of those things, none of those things really does epinephrine fix. So I'll hedge a little bit and say we think these are not helpful and likely harmful, but we don't know. There is a lot of smoke, and where there's smoke, usually there's fire. But we know that CPR, mechanical and manual, cause trauma, and that's bad in polysystem, multi-system trauma. So I'll leave it at neither of these should be priorities. They should be lowest on the list. We're not withholding compressions and epinephrine at MCHD yet, and the reasoning behind that, and we've had lots of discussions about this with the clinical staff and with our district chiefs and with lots of the leaders within our service, and I believe real life comes into play here. And not every arrest is clearly traumatic or medical. When we talk about these cases, we make them clearly trauma or clearly medical. And reviewing charts and being around EMS, you'll see these folks who roll off the road, and maybe they don't roll off the road, but they skid off the road at 35 or 40 on, say, Interstate 45, which runs north-south through Montgomery County, and nobody goes 35 or 40 on I-45, but they go fast enough to hit the concrete barrier in the middle. And is that a trauma arrest or is that medical? Do they have traumatic injury, or did they have acute MI with VF before they skid off the road? So for us, for now, it's about prioritization. And really, if you go back and look at some of those position statements that I mentioned, none of those outright make the claim for removing cardiac arrest compressions or epinephrine. They really stick with prioritization and lack of good evidence. And if you're going to do those things, do them last. Take care of the reversible causes that we discussed first and move on from there. What would you like to add to that, Lindsey?
So I love the concept of deprioritization, right? And I think it's what makes the most sense for all of us based on the evidence that we have currently in the world that we work in. And I like to add a little bit of context to this to kind of support the deprioritization. Sometimes people don't realize this about chest compression. So if you have a euvolemic unobstructed patient who goes into cardiac arrest and we do really good CPR, we're only getting, depending on where you look, the numbers vary a little, 20 to 30% cardiac output in those patients. Okay. So that's like me, a healthy euvolemic person going into cardiac arrest right now. You give me really good chest compressions, you'll maybe get 30% cardiac output. Then we take a patient in true trauma arrest, okay, who is either profoundly hypovolemic or severely obstructed from tension pneumo or tamponade. You're going to achieve basically nothing by compressing on their chest, with a little bit of the theoretical harm being done from worsening vascular damage, organ damage, rib fractures causing organ damage, those types of things. So it simply doesn't make sense in the presence of an obvious trauma arrest to start pushing on their chest before those reversible things have been addressed, right? Because you're not going to get anything out of it. You're not getting much out of it at baseline, and you're really not going to get much out of it if there's no volume or there's a severe obstruction. So that just kind of paints the picture of why it's so important to prioritize the things that matter. Once we are able to fill the tank, once we are able to relieve the tension or potentially relieve the tamponade, or we've done as much as we can possibly do towards those things, then we can consider compressions, and then we might get a little bit more bang for our buck out of them.
I'd throw no delay in loading the patient and initiating transport, access, uh, airway adjuncts, oxygenation, ventilation, TXA, all the things that we do for our traumatic arrest patients and our peri-arrest trauma patients need to come before epi and compressions. So I would throw everything in the mix as a higher priority. The last piece I would say, and we've experienced some of this within Montgomery County, I know you can speak to this, Lindsey, is if you're going to make a protocol change like this and you're going to deprioritize epi or you're going to deprioritize chest compressions or even remove them, you have to communicate this to your partners and your stakeholders. Here in Montgomery County, if we showed up on a cardiac arrest, a traumatic arrest, and we didn't perform compressions, our fire partners would be flabbergasted. They wouldn't know what we were doing, and they think that we were being lax and we were missing a huge step. And why is nobody on the chest? Because that's what they're trained to do. And so if we arrive at the hospital with a patient who maybe went into cardiac arrest during transport, because some of these patients we don't transport patients who are in trauma arrest at MCHD unless we see signs of life or we see signs of sort of perfusion like you discussed initially, Lindsey. If we rolled into the hospital and we weren't doing compressions, the ED staff would think we were being neglectful. So it's communication and sort of discussion of those protocol changes and the why behind them is absolutely necessary if you're going to make those, regardless of how much literature you think backs you up. Not everybody reads that stuff, and not everybody that's not in the ambulance or in the EMS world or in the helicopter thinks about these things the way that we do. So making sure that you don't, you know, cause some communication breakdown between yourself and your partners and your stakeholders is really important when you make big changes like this. Um, there are some situations that are outliers, and like everything else, when you start to paint with a brush that's too broad, you're going to get yourself in trouble. So, Lindsey, before we wrap it up, hit on some situations that are outliers in trauma arrests that may not follow these rules that we talked about.
Yes. So several gray areas here where we need to kind of finagle the guidelines that we just talked about. The first being isolated TBI. The easiest example of this is the self-inflicted gunshot wound to the head that unfortunately most of us see on a semi-regular basis. We know that in TBIs, the two things that we must avoid to not worsen secondary injury are hypoxia and hypotension. And so in these patients, chest compressions and vasopressors are actually going to be a core component of care. And we kind of have to think about it like if you had a patient with a massive spontaneous head bleed, right? You have all of the story backing up a massive subarachnoid, and the patient goes into cardiac arrest on you. What are you going to do? This is the same thing. Yeah, there's a traumatic etiology to it, but you are still dealing with decreased cerebral perfusion, increased intracranial pressure, and that needs to be managed with good perfusion, avoiding hypoxia, and definitely avoiding hypotension as well. The next one is going to be our commotio cordis. So what about Damar Hamlin, right? He got hit in the chest with a football, and they did chest compressions and defibrillated him, and he survived. Yeah, absolutely. But he had a traumatic cause of a medical arrest. The exact same thing can happen with an RNT phenomenon, right? On someone's EKG with PVC that came too early, or if we forgot to hit sync before we cardioverted our VTAC patient and we hit that relative refractory period, right? He just had a football that played the role of hitting that relative refractory period at the wrong time. So we have to be able to, use our clinical judgment like that as clinicians and understand that that needs to be treated medically. The next one is going to be hypothermia. You have a patient that rolled their car presumably several hours ago in the middle of the night. No one saw it happen. You get there, maybe the patient has some signs of trauma and they are in arrest, okay? But it's 20 degrees outside. We have no way of knowing. Well, number one, we have no way of knowing, was it a medical that caused the crash? Okay. But number two, we have another, also no way of knowing, did the patient have some mild injuries, couldn't get out of the car, and then they froze to death, right? So if there is any suspicion that the patient is hypothermic, but they are potentially still viable, we all know the old saying, they're not dead until they're warm and dead. We should be working them. Pregnancy. Resuscitative hysterotomies can be performed primarily for mom to get the baby out, pressure off the vena cava, and resuscitate mom, but also in some cases potentially to resuscitate the baby as well. So my understanding per MCHD protocol, you are, Dr. Patrick, I'll let you elaborate. Are you going to across the board transport pregnant patients even if they are in asystole, or is that up to
Yes, unless there are signs of, just it's incompatible with life. If
Sure.
the patient is decapitated, if there is massive head injury, massive crush injury, massive burns that we unfortunately see, I believe those would be cases where we would perform field termination. We wouldn't take those necessarily to the hospital, but these would be a very, very tight judgment call for our district chiefs in the field, that online medical direction and consultation with myself or Dr. DePasquale would be absolutely advised if there was any question. But to get to that resuscitative hysterotomy is key, and we know that those times there can be variable, upwards of an hour plus or minus, depending on the mechanism of injury, depending on the health status of mom, depending on how far along she is, and all those things we can't really know in the field. So we would much rather err on the side of caution with those patients, even in asystole. I would say, sort of outside of the normal protocol, with asystole being a sign incompatible with life. I think pregnancy would trump it in that situation. Absolutely.
Yeah, agreed. And then two other very gray areas that just want to touch on briefly. One is going to be neurogenic shock. So, in the pre-hospital setting, in the absence of a CT scanner, any multi-system trauma has to be assumed to be hemorrhaging until proven otherwise, and they have to be treated as such. However, there are occasional circumstances where a clinician may suspect an isolated spinal cord injury. So that could be something like a hanging, which, while traumatic, should be treated medically, right? Because that arrest is likely either due to hypoxia and airway issues and or spinal cord injury. And then possibly, maybe, depending on the circumstances, a shallow diving injury if the patient presentation correlates. So in those situations, we know that neurogenic shock is treated a bit differently. I would say that's just something to keep in mind and consider. But if there is any doubt, which there almost always is in the pre-hospital environment, treat like they're bleeding until proven otherwise. And then the very last thing I just wanted to mention was possible crush syndrome. These patients certainly have multi-system trauma. They have been crushed under something very heavy for a prolonged period of time. I just wanted to mention that it is possible for them to have a true cardiac etiology of arrest from the acidosis and hyperkalemia that can occur systemically after release. So depending on your guidelines there, with things like calcium, bicarb, albuterol, fluids, whatever, that's just something to keep in mind as well, that while they are certainly going to be dealing with multi-system trauma, you may also have to concurrently be addressing a true cardiac issue that is happening alongside that.
I'll chime in here and just say that normally, from a neurogenic shock standpoint, I teach the medics, and we teach the medics, that this is a diagnosis of exclusion in the 911 setting. But we're talking to Lindsey today, who works in the world of helicopter EMS. So if you are transferring a patient that has CT scans completed, that has neurogenic shock, you're going to transport them likely on phenylephrine. And so that is a concept that you will see and take care of because the diagnosis has already been made. Just for the MCHD mantra out there, if they're hemorrhagic in the field without imaging, it's hemorrhagic shock before we get to neurogenic shock. We have to treat that as a diagnosis of exclusion. But there are other folks out there in EMS, and this is a good reminder, that may know that diagnosis and have to really manage neurogenic shock specifically. The second piece is really important on that mantra kick, and that is, if we're in doubt, if we're unsure whether it's trauma or medical, then we're going to treat it as a medical arrest until proven otherwise. And we're going to do compressions and we're going to do epi, because we know that if it's a medical arrest, compression fraction, hands on chest, early defibrillation, and if it's not shockable, early epinephrine can potentially be life-saving. So if you're unsure, treat it medical at MCHD. And so if you're not at MCHD, then follow your protocols as always. This is a great point to wrap up. There's so many topics in here that we've hit, Lindsey, that really are worthy of an entire additional episode, especially when it gets to how do we know whether the patient is in arrest or not. And this dichotomy of we're performing CPR versus we're performing resuscitation, it's all been dependent and hinged upon a mechanical pulse for our whole careers. And we know now that that's not adequate, that our ability to detect a mechanical pulse is terrible. And the idea that there's probably going to be some gray zone of perfusion that exists in there. When do we start compressions? When do we manage it as an arrest versus when do we manage it as shock resuscitation, whether we're talking medical or trauma? There's a ton of devils in those details that we don't have time to touch on today. Maybe that's part 2 of this discussion, because that really is the second part of the case that you presented, and that is you had clear signs of life, end tidal, ultrasound, narrow complex, and then the hospital didn't feel a pulse and moved entirely towards the CPR resuscitation of an arrest approach, which likely wasn't the right thing to do. And so how do we guide that? There's a lot of answers in there we don't know, but maybe we can plan for part 2 of this discussion. We're up on time today, so let me wrap it up with trauma arrests need a trauma approach. That's very clear. So your reversible causes in medical arrests and your reversible causes in trauma arrests are almost entirely separate. So learn those, think about those with different lenses in your glasses when you're looking at a trauma patient versus a medical patient. Reversible causes: oxygenation and ventilation, volume, tension, and tamponade. Think about those, work through them, consider them, whether or not you have ultrasound, finger thoracostomy versus needle thoracostomy, blood products, TXA, calcium. There's going to be variable within your service, but think of the trauma reversible causes when you take care of a traumatic arrest. Scene time, definitive care, definitive intervention, getting the patient 2 blood products or providing those, getting TXA on board, those are all vital. CPR and epinephrine are last at MCHD. I would say that most of our governing bodies, ACS, NAEMSP, ACEP, ANSCOR, all are agreeable there. Sometimes medical and trauma can be confusing. If they are confusing you, then you probably don't need tourniquets or pericardial drainage. It's probably going to be that in-betweener, right? If you're putting a tourniquet on, it's pretty clearly a traumatic hemorrhage arrest situation. If you're in between at MCHD, we're going to treat it as medical and manage it under that set of protocols. Isolated TBIs need brain perfusion. The only pressor trauma indication at MCHD is that traumatic brain injury where we see brain perfusion compromise. We're looking at the EPIC trial, just like Lindsey said, hypoxia and hypotension just torpedo our outcomes when it comes to traumatic brain injury. So that's the time at MCHD when we see altered mental status and evidence of head trauma. Pressors are an option in that situation. So at that's a good spot for us to wrap up. Lindsey, do you have anything else you'd like to add before we close it up?
No, this was wonderful, Dr. Patrick. Thank you so much for having me.
Yeah, I'm gonna have to bring you back and discuss the second half of your patient, and that is how do we know when they're in arrest versus not? Because that's a topic I've been looking at pretty closely here over the last few weeks, and no one knows the answer. So that's part 2 of this episode. So as always,
I'm absolutely up for it.
awesome. We're going to do it. As always, if you have questions, concerns, ideas for future podcasts, email us podcast@mchd-tx.org. Leave us a like, leave us a review wherever you listen to your podcast. Subscribe and follow if you're watching on YouTube. There's no video for today's episode, but there are folks out there that watch this on YouTube, so please subscribe. It brings our information to you without you even having to work for it. Check the references for all the stuff that we discussed today in the show notes. We'll link all of these studies and these position statements so you can think about them and take them to your service. As always, we'll be back with an episode again soon. Thank you all for listening.
This podcast was brought to you by the Montgomery County Hospital District, Texas. Production and editing by Andrew Adams. Questions or comments, which are always welcome, can be sent to podcast@mchd-tx.org. Make sure to subscribe above to keep updated to all our future casts. Music, copyright, Kevin MacLeod, Incompetech.com, licensed under Creative Commons by Attribution 3.0.